Assalamu alaikum to all. My name is Dr. Saad from Khan University Hospital. So, on behalf of PSA Karachi, it's my pleasure to welcome you all to the PSA online lecture series on cardiothoracic anesthesia, in which we are focusing mainly on the evidence based practices and recent guidelines and updates in anesthesia, intensive care, and pain management. So today's marks the eighth lecture of this series, and the topic of today's presentation is integration of microcirculatory and macrocirculatory goals in perioperative hemodynamic management, which is a very important topic. So it's an honor to welcome our esteemed speaker, Dr. Mujahidul Islam. He's a professor and head of Department of Anesthesia at the Rahman Medical Institute in Hayatabad, Peshawar. We are grateful for him for joining us today and sharing his expertise. So, before starting the presentation, there are some general instructions for the participants to please keep your microphones be muted and switch off your videos during the lecture. And kindly post your questions in the chat box either during the lecture or at the end. And so after completion of the talk, please fill out the feedback form, which is required for to obtain your e-certificate. So over to you, Dr. Mujahid, sir.
Thank you, Dr. Saad. Saad, can you hear me?
Yes, sir.
Okay. Shall I start?
Yes, sir. Please start, sir.
Okay. Bismillah ar-Rahman ar-Rahim and Assalamu alaikum, everyone. Thank you, PSA Karachi, for the opportunity to speak on this very important topic, integrating macrocirculatory and microcirculatory goals in perioperative hemodynamic management. At the end of the day, one of our most important responsibilities as anesthesiologists is not just to maintain blood pressure or cardiac output, but to ensure that oxygen actually reaches the tissues and cells where it is needed. For that to happen, both the macrocirculation and microcirculation must function properly and remain in harmony throughout the perioperative period. Dysfunction at either level can result in tissue hypoxia, organ dysfunction, post-operative complications, and poor clinical outcomes. Modern perioperative care has traditionally focused more on the macrocirculation because it is easier to monitor. However, we now know that patients may still develop significant microcirculatory dysfunction despite apparently normal global hemodynamics. In many critically ill and surgical patients, the real problem begins at the microcirculatory and cellular level long before shock becomes clinically apparent. Due to the time constraints over the next 40 to 50 minutes, I will focus mainly on the microcirculation, why it matters, how to assess it, and how we can better integrate it into perioperative hemodynamic management. Uh, I have no conflict of interest to declare, except that all images and infographics used in this presentation are AI generated. They do not represent real patients or clinical cases and are intended only for educational purposes. So, in today's talk, we will start with a clinical case to highlight why the microcirculation is so important. We will then discuss the differences between the macrocirculation and microcirculation, followed by what goes wrong in the microcirculation during critical illness and surgery. After that, we will review commonly used hemodynamic parameters and their limitations. We will then focus on simple bedside methods and monitoring techniques for assessing the microcirculation. And finally, we will summarize the key messages and conclude with questions and discussion. By the end of this presentation, participants should be able to differentiate between macro and microcirculation and understand how oxygen delivery and consumption relate to tissue perfusion. You should be able to explain the main mechanisms of microcirculatory dysfunction and recognize when macro and microcirculation are not aligned. You should also be able to interpret common hemodynamic parameters in relation to tissue perfusion. In addition, you should be able to assess microcirculation at the bedside using clinical signs and understand their limitations, and be familiar with advanced monitoring techniques such as OPS, SDF, and IDF. So, this is a 68-year-old man with a history of controlled hypertension and type 2 diabetes mellitus and stable ischemic heart disease, underwent an exploratory laparotomy for intestinal obstruction. Intraoperatively, his hemodynamics were generally stable, with occasional episodes of hyper and hypotension. Post-operatively, he was transferred to the ICU intubated and mechanically ventilated. He remained hemodynamically stable with all monitored parameters suggesting an uneventful perioperative course. During weaning from mechanical ventilation, the patient became confused and agitated. Blood pressure is low with a map of 60 millimeter of mercury. Urine output is borderline in the last 2 hours at 0.5 ml per kg per hour, and capillary refill time is delayed at 3 seconds. Importantly, lactate is elevated at 4 millimole per liter, and central venous oxygen saturation is reduced at 60%. Overall, these findings are consistent with circulatory shock with evidence of tissue hypoperfusion. So, shock is best understood as a problem of cellular and tissue hypoxia, not simply low blood pressure. It occurs when oxygen supply fails to meet cellular demand, and this can happen in three main ways: reduced oxygen delivery, which is typically a macrocirculatory problem such as low cardiac output, anemia, or hypoxemia; impaired oxygen utilization, which reflects microcirculatory or mitochondrial dysfunction, as seen in conditions like sepsis and increased oxygen demand, where metabolic needs exceed the available supply. In clinical practice, these mechanisms often overlap rather than occur in isolation. Therefore, instead of focusing only on blood pressure, we should always think in terms of oxygen delivery, utilization, and demand. However, it is crucial to recognize that a patient in shock may present as hypertensive, normotensive, or hypotensive. So, what is microcirculation? Microcirculation refers to blood flow through the smallest vessels, terminal arterioles, metarterioles, capillaries, and venules. Lymphatics. Lymphatics are an important but often overlooked part of microcirculation. While blood delivers oxygen, fluid removal mainly depends on the lymphatic system. According to the revised Starling principle, there is little to no reabsorption at the venous end, and most filtered fluid returns via lymphatics. When lymphatic drainage is impaired due to increased venous pressure, mechanical ventilation, or inflammation, fluid accumulates, leading to edema. And this edema increases and this edema basically increases diffusion distance and worsens tissue oxygenation, particularly in sepsis. And the key takeaway is that circulation is not just about flow in, but also effective drainage out via lymphatics. Macrocirculation is the large vessel system that delivers blood to the organs and returns it to the heart. Blood is pumped from heart through arteries to supply oxygen and nutrients and returns via veins for reoxygenation. Functionally, macrocirculation generates cardiac output, maintains mean arterial pressure, and regulates systemic vascular resistance. So, macro circulation acts as the body's highway system, ensuring adequate blood flow. Microcirculation is where blood becomes functionally useful. Its key functions include capillary flow, which ensures blood reaches all tissues, oxygen extraction, where oxygen moves into cells, and mitochondrial function, where oxygen is used to generate energy. So, microcirculation is tightly regulated by local metabolic factors such as oxygen, carbon dioxide, hydrogen ions, and nitric oxide, allowing blood flow to match tissue demand. Macrocirculation and microcirculation function like complementary superheroes, working together to achieve effective tissue perfusion. Think of macrocirculation and microcirculation as two superheroes working together. Macrocirculation moves blood to the body, driven by cardiac output, mean arterial pressure, heart rate, and vascular resistance. It provides the flow. Microcirculation, however, makes that blood useful, ensuring capillary flow, oxygen extraction, mitochondrial energy production, and lactate clearance. It provides the function. So the key concept is hemodynamic coherence. Successful resuscitation requires both flow and function. If if macro circulation is restored, but microcirculation remains impaired, tissue perfusion is still inadequate. So in perioperative period, we must target not just blood flow, but effective tissue oxygenation. Professor Ken Ince, a pioneer in microcirculatory research, fundamentally changed our understanding of tissue perfusion. Using side stream dark field imaging, he demonstrated that restoring macrocirculatory parameters like blood pressure or cardiac output does not necessarily restore microcirculatory flow. This led to the concept of loss of hemodynamic coherence, where macro and micro circulation can become uncoupled, meaning a patient may look stable on monitors while tissue hypoxia persists. So, type 1 microcirculatory dysfunction is heterogeneous flow. This is classically seen in sepsis, septic shock, a systemic inflammatory response syndrome, severe infections, and ECMO. The key mechanism is patchy capillary perfusion, where some capillaries are well perfused while others are not, leading to functional shunting. As a result, oxygen bypass certain capillary beds and extraction becomes inefficient despite normal or even increased flow. The primary problem is flow heterogeneity, driven by endothelial dysfunction, RBC deformability issues, and leukocyte activation. Clinically, this explains why patient may have normal cardiac output but still develop tissue hypoxia. Type 2 is hemodilution. And this is common in cardiac surgery, cardiopulmonary bypass, excessive fluid administration, hospital acquired anemia, and massive crystalloid resuscitation. Here, the main issue is not flow, but reduced oxygen carrying capacity due to low hemoglobin. Even if microvascular flow is adequate, the blood reaching tissues carries insufficient oxygen. The mechanisms involve hemodilution leading to decreased hemoglobin concentration, reduced oxygen content, and impaired delivery at the cellular level. This creates a situation of good flow but inadequate oxygen delivery. Type 3 is vasoconstriction or tamponade. This represents iatrogenic or overcorrection states seen with high dose vasopressors, inotropes, hyperoxia, elevated central venous pressure, cardiac tamponade, or fluid overload causing venous congestion. The key mechanism is reduced microvascular perfusion due to excessive vasoconstriction or high venous pressures. Even when blood pressure appears corrected, microvascular flow may be impaired. Clinically, this is the scenario where MAP is normalized, but tissue perfusion remains poor. Type 4 is tissue edema, and this is seen in capillary leak states such as severe sepsis, ARDS, acute kidney injury with fluid overload, and aggressive fluid resuscitation. The primary issue is increased diffusion distance due to interstitial edema. Even if oxygen delivery to capillary is adequate, oxygen cannot effectively diffuse to the cells. The mechanism involves capillary leak, interstitial fluid accumulation, and impaired oxygen transfer, resulting in cellular hypoxia despite apparently normal hemodynamics. Microcirculatory dysfunction is multifactorial and can result from both disease processes and our own interventions. Therefore, effective management requires moving beyond simply correcting blood pressure or cardiac output and focusing on restoring true tissue perfusion and oxygen utilization at the cellular level. So, what went wrong in this patient? Now, this is a classic case of macro microcirculatory uncoupling. During surgery, the macrocirculation appeared relatively adequate with acceptable blood pressure and overall hemodynamics, but microcirculatory dysfunction had already started at the tissue level. As a result, tissue perfusion and oxygen delivery to the cells were impaired despite seemingly stable circulation. This hidden tissue hypoperfusion later progressed to overt shock in the ICU. The surgical stress response likely played a major role by causing inflammation, endothelial injury, capillary leak, and impaired oxygen utilization, ultimately leading to worsening cellular hypoxia and full blown shock. So, surgical stress, including tissue trauma, ischemia, reperfusion injury, endotoxin release, and cardiopulmonary bypass can lead to microcirculatory failure through multiple interconnected mechanisms. First, surgical stress triggers a strong inflammatory and neurohumoral response, cytokine release, endothelial activation, and leukocyte adhesion produce heterogeneous capillary blood flow, so some tissues remain underperfused despite normal blood pressure and cardiac output. Second, endothelial injury and glycocalyx shedding increase capillary permeability. This causes capillary leak and tissue edema, increasing the diffusion distance for oxygen and impairing oxygen delivery to cells. Third, large volume fluids and cardiopulmonary bypass can cause hemodilution. Reduced hemoglobin lowers oxygen carrying capacity and alters blood rheology, reducing effective tissue oxygenation. Anesthesia and vasopressors can also disturb microvascular flow. Excessive vasodilation or vasoconstriction may impair capillary recruitment and create maldistribution of blood flow within the microcirculation. Venous congestion and elevated CVP further worsen perfusion by reducing the arteriovenous pressure gradient and promoting tissue edema, especially affecting organs such as the liver, kidneys, and gut. Ischemia reperfusion injury generates reactive oxygen species, and endothelial damage, leading to capillary obstruction and impaired cellular oxygen utilization. At the same time, red blood cell deformability decreases and blood viscosity may increase, making capillary flow less efficient and worsening oxygen extraction. And finally, mitochondrial dysfunction develops where oxygen delivery may appear adequate, but cells are unable to utilize oxygen effectively for ATP production, resulting in cytopathic hypoxia. Together, these mechanisms lead to maldistribution of blood flow, impaired oxygen delivery and utilization, tissue hypoxia, organ dysfunction, and ultimately microcirculatory failure. Let's discuss macrocirculatory hemodynamic parameters, which reflect global blood flow driven by the heart and large vessels. So we start with the basic bedside parameters like MAP, blood pressure components, heart rate, shock index, and urine output. These are first line indicators of perfusion. Next are flow variables, including cardiac output and stroke volume, which reflect how much blood the heart is pumping. Preload can be assessed either as static pressures like CVP and pulmonary capillary wedge pressure, or more accurately as volumetric preload such as global end diastolic volume and intrathoracic blood volume. Afterload is represented by systemic and pulmonary vascular resistance, indicating the resistance the heart must pump against. So contractility includes measures like ejection fraction and cardiac power output, reflecting myocardial performance. And finally, the dynamic hemodynamic parameters such as pulse pressure variation and passive leg raise are useful to predict fluid responsiveness. The key takeaway is that no single parameter is sufficient, and these variables must be integrated to guide hemodynamic management. So this slide shows three simple ways to assess microcirculation. First, video microscopy allows us directly see capillary flow, but it is not widely available. Second, clinical signs like capillary refill time, mottling, and temperature are quick and practical at the bedside. Third, the biochemical markers and near infrared spectroscopy give indirect information about tissue perfusion. So these are direct methods for assessing microcirculation. The main technologies include OPS or orthogonal polarization spectral imaging, which was the first generation technique. STF or side stream dark field imaging, which became the most widely used method in research and clinical practice. And IDF or incident dark field imaging, also known as cytocam, which is the latest generation technology and provides superior image quality, better resolution, and improved visualization of the microcirculation. About 25 years ago, the first generation of handheld vital video microscopes was introduced, marking a major step forward in our ability to assess the microcirculation directly at the bedside. OPS uses polarized light to illuminate tissue and deducts reflected light that is depolarized by the hemoglobin, allowing visualization of red blood cells without contrast agents. However, image quality was limited with relatively low resolution and more motion artifacts. SDF imaging, introduced in 2007, improved upon OPS technology. It uses green LED light at around 530 nanometer, which is strongly absorbed by hemoglobin, making red blood cells appear as dark moving structures against a bright background. This significantly enhanced image contrast and clarity, making it more practical for bedside use, especially in ICU and perioperative settings. IDF imaging, the latest generation, was introduced in 2015 with devices like the Cytocam. It uses high resolution digital imaging and optimized illumination to provide superior image quality, better capillary detail, and reduced pressure artifacts. It is lighter, more user friendly, and allows more accurate quantitative analysis of microcirculation. Video microscopy mainly assess two things: capillary red blood cell flow and capillary vessel density. Together, adequate RBC flow and sufficient vessel density are essential for effective tissue oxygenation. Disturbance in either can impair cellular oxygen delivery and organ function. So, based on RBC flow and vessel density, several microcirculatory parameters are measured. Flow is assessed using the microvascular flow index, which ranges from no flow to continuous flow and also provides information on heterogeneity index and the proportion of perfused vessels. Density is evaluated using total vessel density, representing all vessels, and functional capillary density, representing perfused vessels. RBC velocity adds insight into flow dynamics, while TRBCP serves as a composite variable reflecting overall oxygen delivery. The perfused boundary region indicates glycocalyx integrity, where higher values suggesting damage. It is important to note that values depend on the analysis method, and currently analysis is performed offline rather than in real time. Video microscopy has been available since 1999, but it is still not widely adopted in routine clinical practice, especially in the perioperative setting. There are two major reasons for this. First, obtaining high quality images without artifacts is technically challenging and requires significant experience and expertise. Second, image analysis is often time consuming and not readily available in real time. In addition, sublingual microcirculatory assessment has several important limitations that restrict its routine clinical use. One major limitation is that it reflects only oral mucosal perfusion and may not accurately represent perfusion in vital organs such as the gut, kidneys, or brain. This is particularly important in conditions like sepsis or during vasopressor therapy, where microcirculatory alterations can vary significantly between organs. Interpretation is also highly context dependent. Anesthetic agents and vasoactive drugs can substantially influence microcirculatory flow, making it difficult to differentiate physiological drug effects from true pathological changes. There are also important practical limitations in the perioperative environment. Airway devices, surgical drapes, and patient positioning frequently restrict access to the sublingual area. So, monitoring is usually intermittent rather than continuous. Another challenge is that the technique is highly operator dependent. Excessive probe pressure, motion artifacts, secretions, or blood can significantly affect image quality and reduce reliability and reproducibility. Furthermore, most microcirculatory parameters still require offline analysis, limiting real time clinical decision making and reducing usefulness in rapidly changing perioperative situations. Finally, there is currently a lack of standardized targets, protocols, and treatment strategies based on microcirculatory findings. This makes integration into routine perioperative practice difficult and often time consuming. So, the overall key message is that video microscopy is a valuable adjunct for understanding microcirculation, but it should not be considered a stand-alone measure of global perfusion, particularly in the perioperative setting. Simple bedside clinical science can provide rapid and valuable insight into microcirculatory perfusion, but they must always be interpreted in clinical context. Capillary refill time is quick and practical. Less than 2 to 3 seconds usually suggests adequate perfusion, whereas prolonged CRT may indicate hypoperfusion or shock. However, it can be influenced by factors such as age, temperature, and observer variability. Skin mottling, particularly around the knees, reflects microvascular dysfunction. Higher mottling scores are associated with poorer perfusion and increased mortality, especially in the septic shock, although assessment may be subjective and difficult in some patients. Skin temperature assessment compares peripheral and central temperature. Warm extremities generally suggest adequate perfusion, whereas cold extremities and a large temperature gradient indicate vasoconstriction and impaired microcirculation. This assessment, however, can also be affected by environmental temperature and vasoactive drugs. So again, the key message is that these signs reflect peripheral perfusion rather than direct visualization of the microcirculation and should always be integrated with other macro and microcirculatory parameters and the overall clinical picture. Although the Andromeda shock trial was conducted in septic patients, its message is highly relevant to the perioperative setting. It showed that targeting capillary refill time resulted in less fluid use and faster resolution of shock compared to lactate guided resuscitation. In perioperative patients, capillary refill time is a helpful tool, especially in resource limited setting that can deduct occult hypoperfusion and prevent over resuscitation, especially during high risk surgery and in high risk patients. Assessing tissue perfusion in real clinical practice is far more difficult than it may initially appear. The fundamental problem in shock is not simply low blood pressure or reduced cardiac output, it is failure at the cellular level, either inadequate oxygen delivery or, more importantly, impaired oxygen utilization. And this is where the major challenge lies. So we cannot directly visualize the microcirculation at the bedside in routine clinical practice. And the clinical signs we commonly rely on are often late, non-specific, and relatively insensitive. Therefore, in everyday practice, we depend on surrogate markers such as mixed venous oxygen saturation, lactate, the PCO2 gap, and NURS, which help reflect the balance between oxygen delivery and oxygen consumption. Although most of the evidence for these markers comes from studies in sepsis and septic shock, the underlying physiology is universal and equally relevant to perioperative and critically ill surgical patients. However, and this is critical, these markers are not stand-alone targets. If interpreted in isolation, they can mislead us and even result in inappropriate resuscitation. So, what we are really trying to understand are three fundamental questions. Number one, is blood flow adequate at the macrocirculatory level? Is oxygen delivery sufficient at the microcirculatory level? And most importantly, is oxygen actually being utilized by the cells and mitochondria to produce ATP? Because ultimately, normal blood pressure, cardiac output, or oxygen saturation do not always guarantee adequate tissue perfusion or cellular oxygen utilization. This is the point where biochemical markers such as lactate, mixed venous oxygen saturation, and the PCO2 gap become clinically valuable, especially when interpreted alongside bedside perfusion assessment and within the overall physiological context. Let's discuss some basics. So, oxygen transport is determined by three key components. oxygenation, delivery, and consumption. First, oxygenation refers to how well oxygen is loaded onto hemoglobin in the lungs. Next, oxygen delivery or DO2 is the amount of oxygen reaching tissues. It depends on two main factors, cardiac output and arterial oxygen content. Cardiac output is driven by stroke volume and heart rate, and stroke volume itself depends on preload, afterload, and contractility. Arterial oxygen content is primarily determined by hemoglobin concentration and oxygen saturation, with a very small contribution from dissolved oxygen. Finally, the oxygen consumption reflects how much oxygen tissues actually use. So, clinically, improving oxygen delivery means optimizing cardiac output, hemoglobin, and oxygen saturation. Oxygen consumption is the product of cardiac output and the arterial venous oxygen content difference, and the oxygen extraction ratio reflects how much of the delivered oxygen is actually utilized by the tissues. Under normal conditions, oxygen delivery exceeds demand. So, oxygen consumption remains independent of delivery. When demand increases, the body first compensates by increasing cardiac output and, if needed, by increasing oxygen extraction, reflected as a fall in mixed venous oxygen saturation. However, when both mechanisms fail, mixed venous oxygen saturation drops significantly, critical DO2 is reached, and anaerobic metabolism begins, leading to lactate rise. This marks the transition to delivery dependent oxygen consumption and tissue hypoxia. Clinically, falling mixed venous oxygen saturation with rising lactate signals failure of compensation and progression toward decompensated shock. Mixed venous oxygen saturation reflects the balance between oxygen delivery and consumption. It's not just a number, it's a physiological signal. A low mixed venous oxygen saturation indicates inadequate delivery or increased demand. So we need to improve delivery of oxygen. But a high mixed venous oxygen saturation, especially in sepsis, is equally concerning. It suggests impaired oxygen extraction due to microcirculatory or cellular dysfunction. So both low and high values of mixed venous oxygen saturation can be abnormal. And most importantly, a normal mixed venous oxygen saturation does not exclude hypoperfusion. Always interpret mixed venous oxygen saturation in context, along with lactate, PCO2 gap, and clinical signs to guide appropriate resuscitation. This table shows how mixed venous oxygen saturation reflects the adequacy of oxygen delivery and compensation. At normal levels of 65 to 80%, there is a good balance between delivery and demand. At 50 to 65%, the body compensates by increasing oxygen extraction. When it falls further to 30 to 50%, compensation fails. This is critical DO2, and the patient shifts to anaerobic metabolism with rising lactate. And below 25%, this represents severe tissue hypoxia and impending cell death. This figure summarizes the major pathways of cellular energy metabolism and explains the relationship between glycolysis, pyruvate, lactate, the Krebs cycle, and oxidative phosphorylation. Glucose undergoes glycolysis to produce pyruvate, generating a small amount of ATP and converting NAD to NADH. Under normal aerobic conditions, pyruvate enters the mitochondria and is converted by pyruvate dehydrogenase into acetyl-CoA, which enters the Krebs cycle and oxidative phosphorylation to produce large amounts of ATP. When oxygen delivery is reduced or mitochondrial function is impaired, pyruvate is converted into lactate by lactate dehydrogenase. This regenerates NAD, allowing glycolysis and ATP production to continue. Therefore, lactate formation is not simply a marker of hypoxia, but an adaptive mechanism to maintain cellular energy production during stress. So, this figure illustrates the major pathways of lactate clearance and highlights that lactate is not simply a waste product, but an important metabolic fuel. The liver is the main site of lactate clearance. Lactate is converted back into pyruvate, which can either undergo gluconeogenesis to form glucose through the Cori cycle or enter oxidative metabolism to produce ATP. Mitochondria rich tissues such as the heart, brain, and skeletal muscles can also directly use lactate as an energy source by converting it into pyruvate and then acetyl CoA for aerobic metabolism. The kidneys contribute to lactate clearance through metabolism and excretion. Lactate is a key marker of metabolic stress, reflecting imbalance between oxygen delivery and utilization. Importantly, it is not a pure hypoxia marker, especially in sepsis, where non-hypoxic mechanisms like beta adrenergic stimulation and mitochondrial dysfunction contribute. Elevated lactate may indicate microcirculatory failure even when cardiac output is normal. While it has strong prognostic value and lactate clearance guides resuscitation, it is a late and non-specific marker. Therefore, lactate should always be interpreted within the appropriate clinical context. PCO2 gap is simply the difference between the carbon dioxide levels in venous blood and arterial blood. In simple terms, it tells us how well blood flow is removing carbon dioxide produced by the tissues. If blood flow is slow or stagnant, carbon dioxide accumulates in the tissues and the PCO2 gap increases. PCO2 gap is therefore considered a flow marker, not an oxygenation marker. It reflects how effectively blood flow is clearing carbon dioxide from the tissues. Clinically, PCO2 gap greater than 6 mmHg suggests low blood flow or circulatory stagnation, even when blood pressure, MAP, or oxygen delivery appear adequate. This makes it particularly useful for detecting occult hypoperfusion and microcirculatory failure. Another important point is that a normal PCO2 gap does not exclude tissue hypoxia, and elevated values may persist in sepsis because of microvascular shunting, even when cardiac output is normal or high. So, at the bedside, the PCO2 gap should be interpreted as a marker of perfusion adequacy and always assessed within the appropriate clinical context. The PCO2 gap to arteriovenous oxygen content ratio is the ratio between the venous to arterial carbon dioxide difference and the arterial to venous oxygen content difference. In simple terms, it helps us understand whether the tissues are producing excess carbon dioxide because they are not receiving enough oxygen, and it is considered an indirect marker of anaerobic metabolism and tissue hypoxia. The PCO2 gap to arteriovenous oxygen content ratio is a surrogate of the respiratory quotient, reflecting the balance between oxygen consumption and carbon dioxide production. A value greater than 1.4 suggests anaerobic metabolism, meaning oxygen delivery is insufficient to meet cellular demand. Clinically, this is extremely valuable because it can detect tissue hypoxia earlier than lactate, helping identify occurred hypoperfusion even when conventional hemodynamic parameters appear normal. And importantly, if this ratio is elevated while lactate remains normal, it may indicate early shock or evolving tissue hypoxia. In contrast, a normal ratio with elevated lactate suggests that the lactate elevation may be due to non-hypoxic causes rather than impaired perfusion. So at the bedside, this ratio serves as a useful tool to guide timely and targeted resuscitation while helping avoid unnecessary or harmful over resuscitation. NIRS provides a non-invasive real-time assessment of regional microcirculatory oxygenation, reflecting the balance between oxygen delivery and utilization at the tissue level. Clinically, RSO2 below 50% or a drop greater than 20% indicates significant microvascular hypoperfusion and early tissue hypoxia, even before global parameters change. However, an important limitation is that NIRS is venous weighted and behaves like mixed venous oxygen saturation. So, in sepsis, it may be falsely elevated due to impaired oxygen extraction despite ongoing hypoxia. Therefore, NIRS is best used as a trend monitor for regional perfusion and must always be interpreted within the overall clinical picture. Under normal physiological conditions, DO2 is substantially higher than the amount of oxygen tissue actually required, providing the body with a significant safety reserve. As DO2 begins to decrease, oxygen consumption initially remains stable because compensatory mechanisms increase cardiac output and enhance oxygen extraction. During this early compensatory phase, patients may appear clinically stable with normal blood pressure and heart rate, making early tissue hypoperfusion difficult to recognize. As oxygen delivery continues to decline, a point is eventually reached where compensatory mechanism can no longer maintain adequate tissue or consumption. At this stage, VO2 begins to decrease, indicating the onset of tissue hypoxia. Clinically, this represents a critical transition, often accompanied by subtle changes such as rising lactate levels, mild metabolic acidosis, or reduced urine output, even before full blown hemodynamic instability becomes apparent. In septic shock, the situation is more complex because the problem is not only impaired oxygen delivery, but also abnormalities in the mitochondria and impaired oxygen extraction at the tissue levels. As a result, the critical DO2 is higher than in other forms of shock, and tissues may remain hypoxic despite apparently normal blood pressure and cardiac output. In these patients, mixed venous oxygen saturation may be normal or even elevated, which can be misleading, while lactate levels remain high. This dissociation between apparently adequate macrocirculation and impaired tissue perfusion is known as hemodynamic incoherence. Once oxygen delivery falls below a critical threshold, compensatory mechanisms fail completely. Oxygen extraction reaches its maximum capacity. Mixed venous oxygen saturation decreases, often to around 50%, and the body shifts toward anaerobic metabolism. Clinically, this stage is characterized by a significant rise in lactate and an increased PCO2 gap, reflecting severe tissue hypoperfusion. This marks the onset of organ dysfunction and requires urgent intervention to restore adequate oxygen delivery and tissue perfusion. If there is suspicion of inadequate cardiac output, macrocirculatory failure, or loss of hemodynamic coherence, with microcirculatory, macrocirculatory uncoupling. Start with simple bedside markers such as lactate level greater than 2 millimole per liter and a PCO2 gap to arteriovenous oxygen content ratio above 1.4. These findings indicate a mismatch between oxygen delivery and oxygen consumption, suggesting early anaerobic metabolism or metabolic stress even before obvious clinical deterioration becomes apparent. If mixed venous oxygen saturation is less than 65%, it reflects increased oxygen extraction, meaning oxygen delivery is insufficient relative to demand. The next step is to assess the PCO2 gap. If it is less than 6 millimeter mercury, flow is adequate, and the issue lies with oxygen content or demand. So management should focus on improving oxygenation, correcting anemia, and reducing consumption. If the PCO2 gap is greater than 6 millimeter mercury, this indicates a low flow state, and management should aim to increase cardiac output with fluids if the patient is responsive, or inotropes if not, remembering to optimize flow before transfusing in anemia. If mixed venous oxygen saturation is greater than 80%, this is not reassuring and indicates impaired oxygen extraction. This is typically seen in septic shock, mitochondrial dysfunction, or microcirculatory shunting. Again, assess the PCO2 gap. If it is less than 6 millimeter mercury, flow is adequate, but tissue cannot utilize oxygen. This represents microcirculatory and cellular failure, and management should focus on treating the underlying cause, such as sepsis. If the PCO2 gap is greater than 6 millimeter of mercury, both flow and extraction are impaired, indicating mixed shock, and cardiac output must be improved. Before giving fluids, always assess fluid responsiveness using dynamic tests like passive leg raise or stroke volume variation. Give fluids only if responsive, otherwise use inotropes. If lactate and PCO2 gap are normal and mixed venous oxygen saturation is above 80%, this may actually indicate excess oxygen delivery due to over resuscitation rather than true stability. Clinically, this raises concerns for fluid overload and unnecessary inotrope use. So, the appropriate action is to de escalate therapy and avoid further harm. A special scenario is when lactate is elevated, but mixed venous oxygen saturation and PCO2 gap are normal. This suggests that global perfusion is likely adequate and the issue may be localized hypoxia, impaired lactate clearance due to liver dysfunction, or persistence after prior hypoperfusion. Since lactate is a slow marker, it may lag behind clinical improvement. The key point is not to chase lactate blindly, as a normal PCO2 gap indicates perfusion has already been corrected, and further aggressive treatment may lead to over resuscitation. Most of the data regarding microcirculatory assessment comes from studies in sepsis and septic shock and critically ill ICU patients, while evidence from the perioperative setting remains relatively limited. These guidelines and consensus statements emphasize that microcirculatory dysfunction may persist despite normal MAP and cardiac output. Therefore, hemodynamic management should assess tissue perfusion using parameters such as capillary refill time, mottling, venous oxygen saturation, carbon dioxide derived variables, and lactate trends, rather than relying solely on blood pressure. This is particularly important in major surgery and sepsis, where patients may appear hemodynamically stable despite ongoing cellular hypoperfusion. The key message is that perioperative management should target both macrocirculation and microcirculation to ensure adequate tissue oxygen delivery. The summary of today's presentation is that effective perioperative resuscitation requires integration of macrocirculatory and microcirculatory goals. Macrocirculation ensure delivery, but microcirculation determines whether oxygen actually reaches and is utilized by the cells. Normal values such as MAP, cardiac output, or heart rate do not guarantee adequate tissue perfusion. This is the principle of hemodynamic incoherence. Therefore, management should move beyond correcting numbers alone. We must interpret macrocirculatory parameters in the context of tissue perfusion and actively assess the microcirculation using clinical signs and perfusion markers. Both components must be supported simultaneously, optimizing flow and pressure while ensuring effective capillary perfusion and oxygen utilization. In practice, this means timely recognition of mismatch, targeted use of fluids, vasopressors, and inotropes, and continuous assessment of perfusion. The ultimate goal is not normalization of numbers, but restoration of cellular oxygenation and organ function. The central principle remains: we do not resuscitate numbers, we resuscitate tissues. Thank you.
Thank you so much, Dr. Mujahid, for such an excellent talk and lecture. So, any questions or comments from the participant, you can share it in the chat box.
I think it is all or none phenomena, Dr. Saad.
So, any questions or comment? So, basically, for me, the to summarize this lecture, it's basically the uh, true, true perfusion basically depends on the interaction between macro and microcirculation. So in macrocirculation, such as we have a MAP, we have a cardiac output, and we have an SVR. And in the microcirculation, where the oxygen delivery and cellular exchange basically actually take place occur. So basically, optimal care it should be depend on the you have to basically
Dr. Saad, I can't hear you.
so, Dr. Mujahid, we didn't receive any questions or comments. So, what is a good tissue perfusion? Am I right, sir?
Dr. Saad, I'm unable to hear you somehow. I don't know what's the problem.
Dr. Mujahid, you are here?
Yes, I'm here, but I was unable to hear you.
Sir, are you hearing me now?
It's being
So, sir,
interrupted.
there are no questions or comments in the chat box till yet. Are you hearing me,
I
sir?
I have a
Yes.
comment and a question, if I'm allowed. I'm Dr. Beena.
Yes, please. Yes, please.
So, Dr. Mujahid, first of all, it's really good to hear from you. I'm Dr. Beena. I hope you remember me. So, this is a very excellent talk, and it's very important for everyone to understand the concept of macro and micro circulation. And the comment is that usually we try to we don't understand that the macro circulation targets are there to achieve the microcirculatory goals. So they have to go hand to hand with each other. And you cannot say that my numbers are fine if your microcirculatory targets are not achieved. The other comment is that we should not rely on one tool, that we have to go side by side, that we need to take the trends of lactate, mixed venous, CO2 gap. And this all trends will tell you whether things are going in a right direction or your management is not going into the wrong direction. And I want to ask the question from you that what do you think that in septic patients, when we know that we are dealing with a hyperdynamic circulation, but we still feel that the people has a resistance on starting the inotropes at the right time, and they let the body go through anaerobic metabolism before they decide to start the inotropes. What is your thought about that?
Thank you, Dr. Bina, and it's really grateful to hear from you after a long, long time. How can I forget you? So regarding septic patient, actually, the problem is that in the septic patient, the loss of coherence occurs very early. So the microcirculatory dysfunction in septic patient, it is very early. So we need to assess the microcirculation more vigilantly in this cohort of the patient, and we should target a higher cardiac output, despite these patients already have a adequate cardiac output to achieve good microcirculation. And at the same point, we should also target the underlying pathology which is contributing to these microcirculatory dysfunctions.
Yeah, that's what I want to say. That it's very important to start the inotropes at the
Yeah,
right time, considering that it's a hyperdynamic circulation. One more
yeah.
question you mentioned in the end, that when your things are not going all together, like lactate, mixed venous, and the CO2 gap are not going correlate, and lactate is inappropriate to the other two parameters, then we always tend to look at liver, but we forget intestine. So most of the time, look into your intestine, because in my clinical practice, I have seen a lot of time that patients are having intestinal ischemia because of the prolonged shock state. So that's another comment. And thank you so much, Dr.
Yes.
Mujahid. It was really a nice presentation.
Thank you, Dr. Bina.
Sir, do you want to add something, Dr. Mujahid?
Um, I have done so much already.
Okay, sir. There are question in the chat box.
Yeah.
The base axis deficit sometimes corrected by giving fluids, but when you check the overall parameters, patient may be in very much positive balance. So how to deal it?
So if you remember the four basic types of microcirculatory dysfunction types, so type other than type one, which is heterogeneous flow. So the type two is hemodilution. Type 3 is vasoconstriction and tamponade, and the type 4 is the diffusion problem or the tissue edema. So all the three types, from type 2, type 3, and type 4, uh, this is basically related to excessive or over resuscitation by the crystalloids. So if you are chasing a number and you are unable to achieve it, then you will do more harm than helping the patient.
I hope Dr. Adil, you received the answer. So, no more question, Dr. Mujahid. So, thank you so
Thank
much
you.
for your excellent talk. So, I would like to thank all the participants for joining us today online. So, we are looking forward for your active participation in the future as well. So, please fill out the feedback form, which is required to obtain your e-certificate. Thank you so much, Dr. Mujahid, and thank you all.
Thank you, Dr. Asad, and thank you everyone who has joined this talk. Thank you.
Yeah. Thank you so much. Allah Hafiz.
Okay, Davis.
Allah Hafiz.